Thank you, madam. Can I start the welcome? Anburaj,
Sure,
sir?
sure, definitely.
Thank you, madam. Thank you. அனைவருக்கும் இனிய காலை வணக்கம். First of all, I put forth my sincere thanks to our management of Kalasalingam Group of Institution for accepting wholeheartedly to conduct this 89th International Virtual Learning Series titled on digital storytelling, video narratives, a mode to modify medication taking behavior. With the blessing of Almighty, our founder, Chairman Kalvi Vallal Devathiriti Kalasalingam Ayya, with the support of our Chairman Ilaya Vallal Dr. K. Sridharan sir, I am here to deliver the welcome address for this 89th International Virtual Learning Series in association with the Indian Pharmaceutical Association South Tamil Nadu Local Branch, Head Office at Arulmigu Kalasalingam College of Pharmacy. Today I feel very much honored to welcome. Can you hear, madam?
Yes, I can hear. Yes.
Yeah. Thank you. Today I feel very much honored to welcome our distinguished personality, a veteran teacher, undisputed and researcher, well-known administrator, and honorable resource person, Professor Dr. Uh, Jamuna Rani, madam, to grace this occasion. Faculty of Pharmacy, Mansa University, Malaysia. Most welcome you, madam. Thank you for you being the valuable part of this wonderful session. Let me acquaint you with sterling quality of this eminent personality. It is a great pleasure for all of us that you could find time to be with us in spite of your busy schedule. Your gracious presence is a great honor for us and great motivation and inspiration for our entire student community. Most welcome, Professor Dr. A. Jamuna Rani, madam. Most welcome you, madam.
Thank you. Thank you, Prof.
Finally, I welcome all the respected professors, faculty members, and my dear enthusiastic students. I hope this session will be a good platform for our students to get a good knowledge. So students, kindly utilize this great opportunity to explore your knowledge. Can you hear? Can you hear?
Yes, I can hear.
Please, madam. Thank you, madam. Next, I extend my sincere thanks to Professor Gan Sui, Head Monash University, for Madam reference for conducting this 89th International Virtual Learning Series. Thank you, Professor Gan Sui. Thank you, madam. Thank you. Most welcome you, madam. Thank you, madam. You can
Okay,
proceed
thank
your
you.
presentation, madam. Thank you, madam.
So, shall I start?
Yeah, yes, sir, madam. Sure.
Okay. I just want to confirm my full video, my full slides are open, not my presenter view. Okay. Okay, thank you so much to the organizer, to AKCP and Prof. J. Anburaj to invite me as a speaker for this session. It is quite often for me to receive some queries and doubts on this topic. There's always a doubt on what pharmacists got to do with digital media, or why do pharmacists need to learn about videos. Therefore, before I go deeper to the process of developing video narratives for patients, I would like to just share some information on why video narratives are important in behavioral modification, especially as a tool for patient counseling. So, as a pharmacist, we are always having the challenge in patient counseling to ensure patients receive optimal treatment efficacy. Patient counseling also increase awareness by providing information and assist in behavior modification, whether it is to follow a certain lifestyle changes, diet, or to be adherent to medication. However, we have always been receiving feedback that patient counseling strategy is still inadequate because treatment non-adherence still occur at least 50% in all disease management, especially in chronic illness such as non-communicable diseases. Past 2 decades, a lot of efforts were used in patient counseling by healthcare professionals. Some of the strategies were didactic information, computer technology, written material, audio tapes, videotapes, verbal communication, pictorial, and narratives, or storytelling strategy, which is also started about the same time with other methods but began to get noticed only in the last decade. But there's always this question, which strategy is the best? So when it comes to behavior modification, we have to really consider the patient characteristics, background, capability, and willingness to ensure optimal treatment effect. And each patient are different when it gets more complicated if patients are with several comorbidities. So it is best to practice a combination of strategy for the population. Why is this so? For instance, in medication non-adherence, according to the World Health Organization, WHO, each behavioral theory has its own advantages and disadvantages. And until to date, there's no single theory can explain medication non-adherence adequately. There are many behavioral models which covers various constructs. Here, for example, this framework is based on Anderson's behavioral model and Leventhal's common sense model. The major predictors of medication non-adherence can be grouped as socio-demographic factors, socio-economic factors, disease factors, treatment factors, and psychosocial factors. Therefore, we have to understand the behavioral theories before adapting it to suit the aim of the audio-visual intervention. The video narrative strategy is more inclined to have the ability to influence the psychosocial factors, which is related to emotion, belief, attitude, and perception. In educational strategy, 75% of information is engaged visually and about 13% of it is engaged using our hearing senses. Hence, when a patient sees and hears a video, they have a higher probability of comprehending and reflecting the information. Viewers of any age group would be able to grasp information at a continuous pace or in a relaxed and inducive environment, depending on how the format is delivered. So, talking about psychosocial. Now, remember the scenes of your favorite movies, which are still vivid or got you excited, or made you go for the lifestyle and become a trend in a certain community. Okay, these are all digital multimedia impact to your emotional center received by your audio and your visual senses, which is one factor which can influence your belief, attitude, and perception. Therefore, the digital storytelling in health helps patients to tell their experience to help other peers using the audio-visual technique. However, to date, there is no one audio-visual format which is better than the other. It all comes to personalization, or in other words, patient-specific. We have to be diligent in identifying similar characteristics of a group of patients based on disease, severity, age, gender, health literacy, culture, to ensure that the information and the aim of the counseling is achieved. And the biggest challenge are that the video intervention must also be cost effective, repeatable, and sustainable. But if you look at practicality, as we know, not all these characteristics can be ticked for one strategy. So we must try to at least fulfill the majority need or overcome the barriers of that group if we want the videos to help them. Therefore, if new strategy was planned for a population, several research phases must be done to check systematically if the strategy works. If this is not done, more cost and safety issues are on stakeholders. You may need to refer to various methods to ensure the strategy is feasible and of good quality for the population. Moreover, if it is related to behavior, it is a bigger challenge due to its dynamic changes. So, here is one pathway which I will be sharing with you for the development of video narratives intervention among post-stroke patients. So I will be giving you a summary on how digital video narratives were developed and tested for post-stroke survivors in the biggest tertiary hospital in Malaysia, the Hospital Kuala Lumpur. This whole study describes from preliminary results to the video development and validation, feasibility, and randomized control study. But first, you may ask, why post-stroke patients? Why not other conditions? This is just a brief explanation. Generally, there are two types of stroke, which is ischemic, or we know it as a transient ischemic attack, TIA, and hemorrhagic stroke. The ischemic stroke is more common, but hemorrhagic stroke causes more deaths. However, both type of stroke causes high risk of immobility or paralysis. And it is more worrying that this scenario is affecting our workforce population, the elderly, and definitely increases more health costs. The highest risk or crucial period of a post-stroke patient to get another recurrence is during their first 6 months of the event. Therefore, this intervention aimed to increase patients' awareness and to ensure compliance of preventative medication. The neurology clinic in GHKL had many non-adherence patients with uncontrolled blood pressure. So we explored the needs and barriers of stroke survivors through a qualitative study. Now, this process is extremely important to understand the patient population. There were suggestions from healthcare providers to take previous responses from related disease, such as hypertension, diabetes, hyperlipidemia from published reports in Malaysia. But by doing that, we may risk missing out specific emotional cues or needs, especially if your patient population undergoes various stages of disease severity, such as immobility and self-confidence. So we also undertook a systematic review related to digital media intervention and self-efficacy in medication management. Now, this was a target behavior changes that we intend to observe in this study, especially belief, perception, and self-monitoring action. This review was also needed because there were inadequate studies which I could refer to. So we also needed to determine significant psychosocial constructs identified as themes in the qualitative study. Therefore, following that, a cross-sectional study was carried out among 282 patients. In this study, we also determined the primary outcome measure because our intention was to monitor the video's impact after 1 year of exposure. So in short, the exploratory phase, which is very important, involved specific studies required before attempting to develop a patient-specific video. So in our case, we required a qualitative study, a systematic review, and a cross-sectional study. So the whole exploratory phase gives fundamental input for the characteristics of video narratives. So based on the review, it is best to incorporate scripts with health belief constructs and use layman language, because not everyone has the same vocabulary grip. Many studies applied the health belief model because the patients were in need of motivation, uh, motivation not only from family and society, but also from healthcare professionals. So this HBM model developed by Rosenstock integrates various types of perception and cues towards health promotion as the outcome plan to observe self-efficacy. So this model we felt was the best to be adapted. So other than that, the video requires presentation style acceptable by adults above 35 years old because all of the patients included in the study were in this age group. Among them, about 80% had mobile phones, but about 50% only had good data support. So therefore, we had to look for several platforms such as face-to-face, WhatsApp, or sending to family members who had good data to provide this video at their convenience. The patients also preferred real actors. So preferably a role model, at least people with similar background whom they feel belong. So we came up with this conclusion also because previously I prepared a sample video for a younger age group and they were supportive on how the information was provided. But when I showed a video to my post-stroke patients, majority of them disliked this type of video. I have inserted the video link in the QR code if you want to view it. So after reviewing all the conclusion, the video development phase started off with an expert panel discussion through Delphi method. This is a structured communication technique whereby there will be a facilitator who leads the discussion among several people until they reach a consensus on the questions asked. In this case, we had to have a consensus on the health belief constructs used and the finalized scripts. We had to review patient interview scripts according to the health belief model as a trigger factor for targeted outcome, which was the self-efficacy. So it began with panel expert invitation, followed up with 3 rounds of discussion, and then scripts were finalized with at least 80% consensus. This is the script outline and guide with the health belief model constructs, which we have all discussed from the expert panel. And this is the script as per the guideline. They were also translated to the Malay or English language. The same process was also done for the doctor's interview script. Now, I will be using this diagram to summarize the rest of steps involved. We used a concept of involving an actual neurologist and patient to tell their story so that the viewers would be able to reflect their actions based on the medical advice and at the same time to get motivation to control stroke risk factors from their peer. We had to take several film shots with the patient and doctor at the recording room. We asked them to speak in English and Malay. Then the films were edited and reviewed for several rounds among selected panel of expertise. The most crucial round is the video engagement validation with actual patients, about 15 of them, who agreed to give their comments. So we adapted a questionnaire meant for filming short clips and modified it to suit the validation need of film health related videos. Then the videos were re-edited and finalized. So our work was halfway done until the validation of videos. However, to ensure the usability of the video as planned intervention, we continued with a feasibility and acceptability study. So here we ran a mini RCT with about 60 patients. So due to time and cost limitation, we ran it within 3 months. So the main purpose for this study was to get qualitative feedback from patients about the whole process of the planned intervention. So based on dropout percentage and the ease of video viewing, only minimal adjustment were applied for the actual RCT. So finally, we ran 1-year randomized control trial at Hospital Kuala Lumpur. So this is the flow chart of assessment and number of patients who were recruited and followed up. So we actually showed the video at the baseline, which is at the first time we met the patient, and then at the 6th month, and then at the 12th month, we also assessed, but that is without the video. So there were challenges in terms of sustaining patients throughout the study, and we had help from the hospital staff and doctors. So although we felt 1 year is inadequate for behavioral studies, but there were also promising results among the post-stroke patients, especially in the outcome measure that we wanted, which is self-efficacy, blood pressure measurement, belief, and blood pressure self-monitoring. Well, the main purpose for me to show you all these processes from obtaining results from preliminary phase studies until the final trial. All this because I want to emphasize on the importance, especially if we want to convince policyholders or to modify a fraction of pharmacy practice, the research process has to be done systematically. So our intention was to add this research intervention as an add-on for our patient education effort of MTech, which is the Medication Therapeutic and Adherence Clinic in Malaysia at HKL. So I hope this guide was useful for everybody here. So I hope everybody have gained some insights on the crucial points which I have highlighted. Many thanks for your attention and thank you to the organizer. Okay. Our final, because one I have actually put it in the link at the QR code. Because of yesterday's, right, we couldn't view the video. The final video, however, because Monash policy, it is still with their confidential agreement. So if needed, then we have to get it in writing. So that video, I think we cannot show. It is still with the patient confidential. Yeah. So actually, if you see the my last slide here, okay, so after we have done after the 1 year, this is the self-efficacy, the first one on MUSE. MUSE was the self-efficacy in medication and taking. So what I've noticed that patient without the video, they have actually improved a bit on their scores because of the hospital itself was also giving their own teaching for patient education. But what happened when the patients started viewing our videos, they, I think they had some motivation to be reading on their own and also learn more. So that's where we started seeing the score for the MUSC to improve. And also they started to take care of their own BP measurement on their own also. So we saw some improvement there. So when we are doing behavioral studies, especially, we need to be very precise on what type of questionnaire you want to ask, because from there only we'll know what measure, what type of how are we going to measure to see whether our intervention is was good or not. So choosing the right questionnaires, choosing the right outcome measure will really see whether your intervention is working or not, whether it is effective. So we had to use a belief score, a belief medicine score, and then we had used also the illness perception score, and we also monitored how frequent the patient came for appointments and how frequent they were monitoring the BP themselves. And there was also some slight improvement. So, of course, when we come to behavior, the best is to go for at least for 3 years trial. But we had to cut down to 1 year because of some cost issues. So that is, we saw there was some positive feedback using videos. Yeah. Pardon? Yes. Okay. You mean for the community pharmacies here in India? Okay. Okay. So what I've been telling, it is just a tool. It's a one way of making patient to believe, change their belief. So I think what India is facing and also Malaysia is facing, we had multiracial issues. Like in Malaysia, we have three main race, Chinese, Indians, and Malays. So the main barrier is always language. So I assume in India also there's perception or language barriers are always there. And another thing is the use of herbal remedies and traditional use. And now it's even worse with all kind of information in the internet, where you can just Google up and all kind of information is there. So now the challenge for pharmacists is to actually identify and inform patients how what information is more important for the patient. And it is actually it's it's an art how to actually induce or make a patient believe the pharmacist. So changing the mindset of a patient is the main is the main motivation or the main cause for patient counseling. So if you can make the patient believe you, then counseling will take place. So uh, patient counseling is just not giving information. So we have to actually now change our style of delivering this patient counseling service by actually understanding the patient's barriers, understanding what the patient needs, and then we are giving the information based on their deficit. Hello? Yes. Yeah. Yes. Yeah, definitely. Because like I've explained, even how much we have done in our this study, we only managed to do it for two main language. We did it in English and Malay, because the place where the patients were there, um, we saw the majority of them knows how to talk Malay, but still we had some limitation there, where we missed out Indian patients who only understood Tamil or some other languages. And we also had Chinese patients who only understood Mandarin Cantonese. So they couldn't understand Malay or English. So they were all excluded. We couldn't actually meet these patients and show the videos. So that was one of our limitations. So it's very important, if you want to make digital storytelling very successful, you have to actually develop several videos in various language, and also you have to see how is the practice, how's the behavior of that patients for that race. Because for example, in Malaysia here, the Indians mindset of how they practice their food, their style, their health behavior practice is different compared to the Malays, compared to the Chinese. So we have to first understand this race, and we have to do a different video if we want to really target for a certain behavior change. So as well, same thing in India, you have to actually uh, develop videos based on what the your patient needs, especially the race and that language there. So it's a very long process. It's not just making videos and then putting it in YouTube and show patients. So what I've showed actually, from the time we did a qualitative study, a systematic review, and then we did a cross-sectional, and then followed up, we did a pilot study, which is the feasibility study. And then we did a full trial. In fact, with all this, there was still some limitation. So if you want to, let's say now in India, you want to change of your pharmacy practice, you want to put it on the paper, or you want to change a certain law, or how to change the modules teaching in the pharmacy practice. So these studies, whatever studies that you have done, is documented, so you can actually show some proofs to policy holders, and it can change. So this is my perception here. Com- compare in terms of with what? Okay. Okay. We have not. What I've did a comparison. We did the standard care just now when I showed the RCT. This RCT here. Okay, this one we compared the standard care. Standard care, they were doing personal counseling. The pharmacists there were doing personal counseling, and then they were also giving pamphlets, and also referring patients to MTech, which is a medication therapeutic adherence clinic. That was all ongoing. And we also did the intervention group, followed up the same thing, the personal counseling, but we added on with this video. Now, why was this video different? Was there were two videos. One video was a very short perception or message from the doctor, and another video was from the patient itself. It's the patient, the real patient, who had stroke, and he had paralyzed in his left region, paralyzed, and he talked. And at the end, Sorry, I couldn't show the video here. So at the end, he did give his message and with a very sad tone. So, and it was a very honest video from the patient. So by looking at that, when we showed patients, patients were moved by seeing another patient who actually was representing them. So that's what actually changed a bit because what I have experienced when I met patients, the patient even asked me, they said, I'm having stroke. You are not having the stroke. So how do you know what are we going through? So we always had that. In fact, patients will also think like that to the doctors because they'll tell that they others won't understand how we feel. So what we felt is by doing this video add on to personal face-to-face counseling, everything actually gave a bit touch of the on the emotional and belief side, so they feel motivated to actually um, do better, and they feel that um, stroke is not the final stage. Even though we are paralyzed, we can still improve. At least that mindset has changed a bit for some of the patients here. Yeah. Yes. 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 Yeah. Okay, that is very true, because we had a lot of other studies who collected various patient stories, and they put these patients to advise another patient. But what was the feedback? It was not done in Malaysia. It was done in US, if not mistaken. What they have noticed is that some patients even deteriorated, and they even stopped medication because of the advice of another patient. So actually that way was wrong. So in this we learned from other people's mistakes. So in this intervention that we did, we collected several patients in interview, several patient stories, and that's where the expert panel uh, came in, where after we have collected the video, the interview recordings of this patient, we went through it and we selected the points which we felt was appropriate to be shown to a very specific need of patients. Let's say now out of 20 of them, we saw that this patient need this type self-efficacy problem. So we collected um, the the information needed to improve self-efficacy, and we actually chose the words and the sentences from the patient interview itself. So then we approached back to the patient and said, okay, from this interview, could you actually retell your story, but please just talk on these points. So we asked the patient to tell based on the guide. That's where just now I mentioned about the Delphi method, and we had a guide. So we really need an expert panel to actually guide the patient also. But at the end, when the actual patient tells out their story again, but this actual patient have already in their mind that, okay, I must only tell these points to help my friends. So we kind of modified his way of telling the story. Yes. Conflict. What do you mean? The conflict of using the video, or actually, okay. Okay, okay, sure. So this is what also we experience. Actually, that is when we were recruiting patients and when we were asking whether the patient is interested to be part of the intervention, they agreed. But when we asked the patient that, okay, you have to look at this video and start seeing, some of the patients, when they were watching the video, they stopped halfway and they said, no, I don't want this type of advice like that. So it is also again back to personalization. So we have to actually respect their decision also. And as a pharmacist, we try our best, right? We try to actually help them, but it is at the end is the patient's decision whether they want to follow or not. So we cannot put a force on them, right? So from our study also, we learned that um, at the end, patient decides whether they want to actually see our intervention or get our advice or not. So if they feel offended and or the pharmacists feel that they are not getting good response, we have to respect their decision. That's all. Yes, okay. Okay, sure. I we can always keep in touch if, let's say, there's a future, if those who wants to actually continue or want to know more about this research. Actually, we are still doing now more on the NGOs. The NGO, we are going to involve NGOs, and we are changing it a bit on peer advice. So something like that. It's not more on storytelling. We are doing more on the peer-to-peer intervention. For those who are interested, we can always contact us back. Yes. Okay, sure. Okay, definitely. Okay. Okay. Thank you so much. Okay, bye. Okay, sure. Definitely. Thanks. Okay, bye. Bye.